Well, hello guys, this is Chris back again with the Ancient Scholar. I just want to talk a little bit about failing to get somebody off mechanical ventilation. Lots of different things. We could do something called weaning to exhaustion, where my patient's just not quite ready, and I just keep weaning and liberating and keeping them in spontaneous mode, and then they just poop out, they get exhausted. Other things can include auto-peep, where my patient has air trapping, gas trapping, leads to auto-peep. As we know, auto-peep can increase the work of breathing. It can cause lots of hemodynamic complications, even lead to lung injury. Excessive work of breathing. If I have somebody that has let's say a 6.0 endotracheal tube, let's say they're trying to wean someone like me, big guy, even my ideal body weight's rather large, because I think I'm 6'1", and some change. Clearly, if I had a 6.0 endotracheal tube in me, I'm going to have very high work of breathing. You may want to consider changing it out for a larger tube and then attempting to wean or liberate me. Poor nutritional status, of course. If somebody goes in the ICU and we don't feed them, we're effectively starving them. How well are they going to do starving? When they're in the ICU, they're already critically ill and they're already in a hypermetabolic state. The last thing we should do is deprive them of their food. So often you'll see them start fairly aggressive, either nasal or gastric tube feeding regimens, and sometimes even total parenteral, or TPN, total parenteral nutrition. We can overfeed our patients, give them too much. Maybe they have digestive problems, maybe they're producing a lot of carbon dioxide and they're having difficulties with overfeeding. Decreased levels of magnesium and phosphate can lead to failure to wean, because this can lead to muscle weakness, and muscles won't work effectively, and I'm not able to effectively ventilate. Infection or fever. Maybe somebody came into the hospital with a pneumonia, and we've cleared that pneumonia up, but now they have a urosepsis, or a massive urinary tract infection. And even though the condition that led to the intubation is cleared up, they now have developed another condition, and perhaps that is interfering with our ability to get them off of mechanical ventilation, or liberate them. Major organ failure. Let's say some people maybe had a surgery, there was an insult, they were hypovolemic for a while, and now they're in acute renal failure as a result of that. The acute tubular necrosis or something like that. Clearly, that can be a problem as well. So when we look at when we have somebody and they fail their spontaneous breathing trial, and they're continuing to fail, they're not particularly doing well, we need to assess that whole laundry list of things, and we need to address those things. Because again, I think it's very tempting for a lot of providers to do the spontaneous breathing trial in the morning and go, whoop, didn't pass, see you tomorrow, and then come back in the next day, whoop, didn't pass, see you tomorrow. If we are consistently not able to get a patient to wean or liberate a patient from mechanical ventilation, we need to find out why. Now, there is that 1% that will never come off. We need to recognize that, but we need to recognize there is a massive laundry list of issues that can lead to failure to wean or failure to liberate. And we need to go through that list, we need to assess for those things, and we need to treat those. And be very aggressive about treating those and getting our patient off mechanical ventilation. We don't need to do the spontaneous breathing trial slide, and 2 weeks later we're still going, whoop, didn't pass your trial today, see you again. We really need to knock that stuff off and be aggressive about identifying problems and treating them. Okay guys, so that was the basic introduction to liberation from mechanical ventilation, and I probably imagine that a lot of you are rather confused at this point, because I didn't really tie everything together in a nice tidy little package that you can take home. And the reason is because there is no tidy package when it comes to this. There are lots of different ways of getting the job done. The literature points to in lots of different ways, and there just simply isn't one way to look at this. But the take-home point, I think the take-home point from all this clearly is that if we can successfully liberate patients from mechanical ventilation, they get to go home sooner, they spend less time in the ICU, and they end up having less problems, iatrogenic problems such as ventilator-associated pneumonia, urosepsis, things of that nature. So I know that some people say the big push to get people home is all driven monetarily, and to some extent that is true. We want to boot people out of the hospital to save money. But the other side of that coin, and it's the side of the coin that I find most appealing or most intriguing, is that the sooner we can get patients off the ventilator, out of the ICU, and ultimately back home, the better they do. They have a better quality of life. They don't get infections. The longer you stay in the hospital, the greater your chances of developing some iatrogenic issue, like an infection or falling out of bed and breaking a bone, or having some kind of episode of delirium or becoming malnourished, or a whole laundry list of things. So clearly we as therapists, or obviously this isn't specific just to therapists. I mean, for all I know, residents or interns or med students or nurses or any number of people could be potentially watching this video. So certainly not excluding you guys at all. But clearly we can impact, we as respiratory providers of whatever vocation or profession, clearly make a large impact on how our patients do by being aggressive about getting them off the ventilator. Even though it may not be convenient in some cases, sometimes it's convenient, and I know this as a flight nurse. It has been very convenient at times for me to give a sedative, give an analgesic, give a paralytic, and let the ventilator do everything. My patient's quiet, everything is good. Ultimately, that's not good. Ultimately, that harms the patient, and ultimately we need to change that paradigm if we have that tendency to fall into it. And even I have had to change my paradigm about mechanical ventilation, and I realize that mechanical ventilation is nothing more than a necessary evil. It's great to talk about, there's lots of good theory involved, but mechanical ventilation is not physiologic, it is not natural by any means, and it is something that we do out of necessity, but we don't necessarily like to do it. If we have to put somebody on a ventilator, it's because we are forced to do so. It is because something has forced us to do that, and it is a necessary evil. So again, I know I'm getting a little long-winded here, but I think the take-home point is to be aggressive about correcting the problems that got the patient to the ventilation, correcting any other problems that show up along the way, getting the patient off the ventilator. They may or may not thank you for it, but generally they get to go home sooner and they get to do better. And we don't injure them as much iatrogenically. Okay, guys, hopefully you enjoyed these series of videos. Thank you guys for watching and hanging in there. Take care and good luck in your future as far as ventilator management goes. Bye-bye.